and synapse in the trunk at the same level as the cell body of that preganglionic. Option 2, the axon extends out, hits the trunk, but then instead of synapsing at the same level, goes up, right? Could go up 1 ganglion, 4, 5, or down, ascends or descends, then synapses in the trunk. Third option, it doesn't synapse in the trunk at all. The preganglionic axon goes through the trunk and then heads into the ventral body cavity, and finally synapses on the postganglionic in what type of ganglion? Collateral. Those are the two general types of ganglia, the collateral ganglia and the sympathetic trunk ganglia. There was a third possibility, but this is specific to a particular organ. It's an organ that's innervated by the sympathetic nervous system, not parasympathetic. And it turns out preganglionic axons go all the way out to this organ without synapsing. So there is no ganglion per se with this particular target. But what is it?
Adrenal medulla.
Adrenal medulla. How about the names of the cells of the adrenal medulla? Remember their names?
Kohler.
Chromaffin cells. What do they secrete? Epinephrine, yes, and norepinephrine, or as a group, catecholamines. Roughly 80% of what's secreted is epi, 20% norepi. And then those chemicals get into the bloodstream and function as neurohormones. Sympathetic trunk ganglia is just that. Although you can divide it a little bit, regionally you have cervical, thoracic, lumbar, sacral. The only ones that really have names are the cervical. Do you remember what those were called? Superior, middle, and inferior cervical ganglia. And then collateral, those have names. What do those include?
Cilia.
Superior mesenteric, inferior mesenteric. Parasympathetic. What are the two general categories of parasympathetic ganglia? The two types. The ones that are close to the target, the ones that are actually in the wall of the target.
Intramural and terminal.
Terminal ganglia and intramural. Which ones have named ganglia? The terminal or the intramural? Terminal have names. Intramural do not. No names for any of them. The names of the terminal ganglia? Yes? Ciliary? Which one?
Otic.
Uh-huh. And the other one's a biggie? Pterygopalatine. So, choice A, celiac ganglia. Is that sympathetic or parasympathetic? Sympathetic. Do they contain cell bodies of pre- or post-ganglionic sympathetic neurons? Post. Ciliary ganglia. Sympathetic or parasympathetic?
Parasympathetic.
Parasympathetic. All right, so obviously sympathetic would not be found in that particular ganglion. Cervical, sympathetic, superior mesenteric, sympathetic, inferior mesenteric, sympathetic. So the cervical are just a region of the sympathetic trunk. Right? The top three are the superior, middle, and inferior cervical ganglion. And then superior mesenteric, inferior mesenteric, like celiac, those are examples of collateral ganglion. Is it even sympathetic?
Parasympathetic.
That's it. Parasympathetic. How about the others? Any others parasympathetic besides pelvic? No, the others are all sympathetic. But if they're not the right answer, what does that mean is in those particular nerves? Axons of preganglionic sympathetic nerves. So go back to the three possibilities. Preganglionic sympathetic axon can go into the trunk, synapse at the same level, go into the trunk, ascend, descend before synapsing within the trunk, or go through the trunk, don't synapse in it at all. Go through it, form a nerve that takes you to a particular ganglion, a collateral ganglion, right, within the ventral body cavity. And that's what these other ones do. Like greater splanchnic nerve carries preganglionic sympathetic axons to what? A collateral ganglion, but which one? Celiac. How about lesser splanchnic nerve? Carries preganglionic axons to
Inferior.
superior mesenteric. Lumbar splanchnic nerves? Inferior mesenteric. Carry preganglionic, not post. E carries parasympathetic, not sympathetic at all. D is the right answer. Fine? So the nicknames can help you. Anatomical nickname doesn't help you with this question. A functional does. Anatomical nickname for sympathetic thoracolumbar division, parasympathetic craniosacral. Functional nickname for sympathetic, which reflects the function. Fight or flight division of the ANS. Parasympathetic. There you go. So parasympathetic promotes digestion. To digest, you need to move the gut and you need to secrete in the gut. So to make this a correct statement, change inhibits to stimulates. Yeah. Right? ACH is the neurotransmitter of the parasympathetic division. Muscarinic are the receptors. And this would increase motility and glandular secretion. So remember, parasympathetic is excitatory when it comes to digestive functions, urinary functions, and these are called maintenance functions. How about sympathetic? What effect does sympathetic have on digestive functions, urinary functions? Inhibitory. So we could say binding of norepi to adrenergic receptors within the digestive tract would inhibit motility and glandular secretion. Heart specifically. Which is excitatory? Sympathetic. And in this case, parasympathetic inhibitory. So you can't say across the board, sympathetic is always excitatory and parasympathetic is always inhibitory. It depends on the target organ. So you needed to know beta-3 is on adipocytes. When epi-norepi bind to these beta-3, it tells the adipocytes to break down the triglycerides, which is lipolysis. Beta-1 was another one I gave you. Beta-1's on cardiomyocytes. So when you stimulate those, heart rate goes up. On the same cells, you have muscarinic receptors, and when you stimulate those, heart rate goes down. Parasympathetic brings it down, sympathetic brings it up. Alpha 1 are found on, what does vasoconstriction refer to? Vasovessel constriction, constriction of blood vessels. So blood vessels have alpha 1 receptors. Blood vessels also have beta 2 receptors. To help you remember the different responses, think beta 2 dilation, alpha 1 constriction. Beta dilation, alpha constriction. So when epi, in particular, stimulates those beta 2 receptors, blood vessels dilate. When norepi stimulates those alpha 1 receptors, vasoconstriction. Now the reason I said epi for the beta and norepi for the alpha isn't because the other one doesn't stimulate it, but it turns out beta receptors have a higher binding affinity for epi. Alpha receptors have a higher binding affinity for norepi. Now, which is used as purely a neurotransmitter? Epi or, well, I shouldn't say purely. Which one is used as a sympathetic neurotransmitter? Epi or norepi? It's norepi. So where's the epi coming from?
Adrenal medulla.
The adrenal medulla. So you're only going to see that beta dilation or significant beta dilation when we're activating the adrenal medulla and we're stimulating those chromaffin cells to put lots of epi into circulation. Then you get more of that beta dilation. If it's just norepi being secreted from sympathetic fibers as a neurotransmitter, you primarily get the alpha constriction. The other thing to realize, these beta 2 receptors are not found in all vascular smooth muscle, just the blood vessels in skeletal muscles and the blood vessels serving the heart. So when you have a fight or flight situation and you're increasing sympathetic output everywhere, you're releasing lots of norepi as a neurotransmitter, also epi and norepi as neurohormones. The overall response throughout the body, the global effect, constriction. Because all blood vessels have alpha receptors, so you get global vasoconstriction. But of course, during fight or flight, we want to make sure that skeletal muscle and cardiac muscle, who are going to work harder now, right? Because we're running or fighting. We're calling upon our skeletal muscle system and our heart to prepare us for physical action. We want to make sure that these guys get more blood flow, not less. So of course, you don't want to constrict the blood vessels going to the heart muscle and the skeletal muscles. So to prevent constriction, those blood vessels have a lot of beta receptors. So you end up constricting everywhere except the blood vessels serving the heart muscle and skeletal muscle. That's basically what happens during a fight or flight situation. It's a way to divert blood flow. Everybody else gets a little less so that skeletal muscle and cardiac muscle can get a little more, because they're the ones that are going to be getting us out of this situation. It's a lot easier for parasympathetic because it's just one receptor. It's always muscarinic. And you don't have to learn any subtypes. You don't have to learn M1, M2, M3. You just need to know where nicotinic receptors are used, autonomic ganglia, neuromuscular junctions, and in the brain, and where muscarinic receptors are used. All parasympathetic nervous system targets. Right? But unfortunately, sympathetic, more complicated because you have beta receptors and alpha, and you need to know the subtypes. Alpha 1, alpha 2, beta 1, beta 2, beta 3. The nice thing about beta 3, it's only found in one place, adipose. So that one's a little easier. The other ones you would have to literally memorize, and I would never ask you to do that. But there are some selected receptors you do need to know, like beta 1 of the heart, alpha 1 of blood vessels, and then beta 3 for adipocytes. And I think that's where we left off on the study guide. We're on autonomic nervous system physiology. neurotransmitters and receptors. So last time we looked at general effects and specific effects for parasympathetic, and then we did the same for sympathetic. So the ones you need to know for parasympathetic: muscarinic receptors on the heart result in decreased heart rate when those receptors are stimulated with acetylcholine. At the iris, which is an intrinsic eye muscle, constriction. Right? What's constricting? The iris is the muscle, but what? The pupil. In the bladder, when muscarinic receptors are stimulated, it causes the bladder smooth muscle called detrusor muscle to contract. So it results in emptying or voiding the bladder. And then in the GI tract, when you stimulate those muscarinic receptors, you increase motility and you increase secretion. And then for sympathetic, I think it's just the ones from the quiz. You need to know, yeah, it's the same three. Beta 1 on the heart results in increased heart rate. Beta 3 on adipocytes results in lipolysis. Stimulating alpha 1 receptors, and you can ignore skin because it's not just skin, all blood vessels have them. When you stimulate alpha 1 receptors in the vascular smooth muscle, you get constriction. Okay? And so if we use the term vasoconstriction, you know what we're talking about, constriction of blood vessels, versus bronchoconstriction, which is constriction of bronchioles, airways. And by the way, blood vessels and airways, so the smooth muscle of blood vessels, especially the blood vessels that serve skeletal muscles and the heart, and the smooth muscle in the airways, they use beta 2 receptors. So you get, in both cases, dilation. Beta 2 dilation of blood vessels, beta 2 dilation of airways. So what type of an agonist would you use to improve symptoms of asthma, to open up the airways? But what is it? What is albuterol? It's a beta 2 agonist. Exactly. We also looked at tone, and that goes back to the idea that the autonomic nervous system does not work like a switch, it works like a dial. All sympathetic and parasympathetic fibers release neurotransmitter all the time. It's just a matter of how much. Some target cells receive a lot more stimulation under resting conditions than others. For sympathetic nervous system, vasomotor tone is a good example. Blood vessels are constantly being stimulated by sympathetic fibers, constantly releasing norepi. It's binding to those alpha receptors, and it's keeping our blood vessels partially constricted. So that's kind of the baseline. And maybe the action potential frequency looks something like this, partially constricted. And then from there, if we turn up the dial, frequency goes up, start releasing more neurotransmitter, we get constriction. Well, what if we want to dilate? We start with our baseline, but then from there, you turn the dial down, right? So the frequency goes way down. Start releasing a lot less norepi, less stimulation of those alpha receptors, and that allows the smooth muscle to relax and the vessel dilates. But we have to start in the middle. And then from there, we can achieve full constriction or full dilation. Because remember, we can only use the sympathetic nervous system to control the blood vessels. They don't have dual innervation. So in total, what are the targets that have sympathetic innervation only, no parasympathetic? Blood vessels. And skin's a good example because you have blood vessels in the skin. And there's two other things in the skin that are only innervated by sympathetic. Right? So blood vessels, sweat glands, erector pili muscle. So you could associate all three with the skin, but remember when it comes to blood vessels, it's not just skin blood vessels. All blood vessels are innervated by sympathetic only. And then outside of blood vessels and the skin, what else? Adrenal medulla. We could also add adipose to that list. There's no parasympathetic innervation of adipose, just sympathetic. The example we used for parasympathetic tone was that of heart. And what nerve provides parasympathetic output to the heart? So we can also refer to it as vagal tone. Right? There's constant stimulation through the vagus nerve. So you have vagal tone or parasympathetic tone to the heart. So we're constantly releasing lots of acetylcholine binding to those muscarinic receptors on the cardiomyocytes, and that keeps the heart rate low. We know this because if we cut the vagus nerve, what would happen to heart rate? Shoots up to about 100 beats per minute. And then if you want to get your heart rate above 100, then what do you have to do? You've already turned the dial down as much as you can on parasympathetic, so now you got to turn the dial up on sympathetic. And then you can get the heart rate up even higher. I think the next section is tone, right? I don't know what happened when I started. Oh, there it is. So after autonomic tone, drugs, chemicals that we use as agonists and antagonists. Turns out a lot of the drugs out there manipulate the autonomic nervous system to produce their effects. So you basically have four categories. You have sympathetic agonists, sympathetic antagonists, parasympathetic agonists, parasympathetic antagonists. Now more specifically, which receptors are being stimulated by a parasympathetic agonist? Muscarinic, right? All target cells for the parasympathetic division use muscarinic receptors. So you could call it a parasympathetic agonist, or you could call it a muscarinic agonist, or even a cholinergic agonist, right? Because muscarinic receptors are cholinergic receptors. They're a specific type. Nicotinic receptors are the other type of cholinergic receptor, or ACH receptor. What's another term we use for antagonist? That does a better job of describing what this chemical actually does. Because an antagonist binds to the receptor, but it doesn't stimulate it. Right? Nothing happens to the target cell, but you are blocking the receptor, preventing your endogenous chemicals from binding to it. Blocker. Inhibitor works too. But pretty much everyone has heard of beta blockers. Most of our grandmas and grandpas take beta blockers. A lot of cardiovascular disease out there, a lot of heart failure out there. And when the heart is failing, you need to reduce the workload, and that means decreasing the heart rate and decreasing the force of contraction. And sympathetic is excitatory to the heart. It increases the work of the heart. So what type of a drug would we use to lower heart rate and in turn help lower the workload of the heart? A sympathetic antagonist, an adrenergic receptor blocker. Another term we use is mimetic. A sympathetic agonist can be called a sympathomimetic because the chemical is mimicking the sympathetic nervous system chemicals, epi and norepi. Sympathomimetic. Or parasympathomimetic, something that mimics ACH from the parasympathetic nervous system. Some specific examples, and there's a lot more in the apps manual, but from the study guide, we've got atropine, albuterol, atenolol, and phenylephrine. Atropine is a muscarinic antagonist. So if parasympathetic output is excitatory to the digestive tract, both in terms of motility and secretion, which would include salivation, then you could use a parasympathetic blocker to decrease salivation. And that's what they do. They use atropine. right? It limits salivation because it blocks the effects of ACH on those muscarinic receptors. And which cranial nerves are responsible for providing this parasympathetic output to the salivary glands? Yep, 7 and 9. 7 takes care of submandibular, sublingual. 9 takes care of carotid. Right, so those nerve fibers are releasing ACH. They bind to muscarinic receptors, and it causes the gland to secrete more saliva. We're going to block that with atropine. Albuterol is a beta-2 agonist. What effect is that going to have on heart rate? Shouldn't have any, because heart uses beta-1 receptors, and this chemical is specific to beta-2. And this is good. This is what we want, because you have less side effects. The more specific the drug, the better. If we just used a beta agonist, not a beta-2 agonist, well, yeah, we would get the relief of asthmatic symptoms, right? The difficulty breathing, because that beta agonist would open the airways. But what else would happen? Your heart rate would be high. Your blood pressure would be elevated, and we may not want that, right? We just want to dilate those airways. That was the problem with the old inhalers. Like back in the day, you could get Primatene Mist over the counter. It was not selective. It was just a beta agonist. And it was really bad for people that already had high blood pressure. It made it even worse. Atenolol is a beta blocker. It is specific to beta-1. This is good because we don't want to give the person something that's going to constrict their airways and make breathing more difficult. Because a lot of people have asthma anyway, on top of the cardiovascular issue that we're trying to treat. So by giving atenolol, we can just decrease the heart rate, we can decrease the workload of the heart without causing constriction of the airways. Rare cooperative effects. For the most part, we have antagonistic effects. Whatever sympathetic does, parasympathetic does the opposite. Right? For all the target organs that have dual innervation. Oh, thanks for telling me. For all the targets that have dual innervation, sympathetic and parasympathetic typically have opposing effects. The only example where this is not the case, reproductive system. And physiologically, we're talking about the physiology of intercourse or the sexual response. And I mentioned this last time. The two systems work together. Parasympathetic is responsible for arousal phase, which includes engorgement of erectile tissues, penis in males, clitoris in females, breasts in females. And then sympathetic is responsible for the orgasm phase in both males and females. Other than that, they oppose each other. Localized versus diffuse effects. Localized means we're just targeting few target cells. Diffuse, we're reaching lots of target cells. If you compare the autonomic nervous system to the somatic nervous system, which one is more direct, more localized? Which one gives you more precise control over the target cells? Somatic by far. Right? That one axon terminal has an effect on one muscle cell. Now you can have an axon that branches into 5 telodendria, 5 branches, and each one of those branches is going to form a neuromuscular junction with a different muscle fiber. So that would be a pretty small motor unit. But out of all the muscle fibers in that target organ, you're only going to stimulate 5. We don't see anything like that with the autonomic nervous system. And we're dealing with cardiac muscle and smooth muscle, where there is no such thing as motor unit recruitment. We can't get just a few cardiomyocytes to contract or a few smooth muscle cells. It's all or none for the most part. So we don't have to be so careful. We can just sprinkle neurotransmitter over a big bunch of cells to get our effect. We don't have to have direct contact. I mean, if you look at the neuromuscular junction, those two cells are almost touching. Separating the axon terminal of your alpha motor neuron from your muscle cell, nanometers, just the distance across that synaptic cleft. But remember what it looked like, and we saw this back in chapter 13, when a autonomic fiber is innervating its target. We didn't see axon terminals at all. Instead, let's say we have a bunch of smooth muscle cells. We have axon branches that kind of drape over the target cells, and there are swellings along the length of these branches rather than axon terminals at the end. Do you remember what those swellings were called? Starts with a V, varicosities, and they just sprinkle like a sprinkler system. Dump neurotransmitter all over the place, reaching lots of cells in one shot. That's an example of diffuse versus localized effects. Another example, comparing sympathetic to parasympathetic. With the parasympathetic division, each preganglionic neuron synapses with one, maybe just a few postganglionic neurons. In turn, those few postganglionic neurons, or one, is going to reach a few target cells. So this produces short-lived but very localized effects. Sympathetic, when a preganglionic becomes active, it ends up activating many, many postganglionic neurons. That one pre is going to synapse with many post. In turn, those postganglionic neurons release neurotransmitter affecting many, many target cells. These effects tend to be long-lived and more diffuse. So comparing the two, you could say parasympathetic is a little bit more precise. The effects are a little more localized compared to sympathetic. Note, individual organs can be affected for more localized effects. Meaning, if you look at all the effector organs of the sympathetic nervous system, we don't have to stimulate all of them if all we need to do is dilate the pupils or sweat. We can send signals down the appropriate nerves just to those target organs, just to dilate the pupils, just to stimulate the sweat glands, without affecting everything else. Right? We can do that with sympathetic and parasympathetic. But the other thing we can do with sympathetic, not para, but just sympathetic, we can activate the whole system, so all postganglionic fibers are dumping neurotransmitter at the same time. This is what happens during fight or flight. And not only are we reaching all the target cells using the sympathetic fibers, we're reaching them by dumping epi and norepi into circulation. During fight or flight, the adrenal medulla gets stimulated. And we're going to put a bunch of epi norepi into the bloodstream, and all the targets that have receptors for epi norepi are affected. So in that case, you get sweating, dilation of the pupils, increased mental alertness, breakdown of glycogen in the liver, breakdown of lipids in the adipose, increased metabolic rate of skeletal muscles, dilation of airways. You get all of these effects, increased heart rate, blood pressure, all at once. Widespread, very diffuse. Control of the autonomic nervous system. In the end, who is the boss of the ANS? Hypothalamus. Hey, look, they even say the boss. Thought I made that up. These higher brain centers that are connected to the hypothalamus are largely involved in emotion, right? The limbic system. And we talked about this, the fact that the hypothalamus connects the limbic system to the autonomic nervous system. And that's the basis for psychosomatic illness, right? Your emotional state is having an influence on sympathetic output, causing your heart rate to be high and your blood pressure to be high. Right? So you could have hypertension even though there's nothing really wrong with the body, nothing wrong with the cardiovascular system, it's just your emotional state. Right? Stress and the effect that that's having on your heart through the autonomic nervous system. In general, visceral reflexes control visceral targets. Visceral reflexes are responsible for most sympathetic and parasympathetic output. When there's a crisis, when there's a threat, a fight or flight situation, that's when the hypothalamus steps in and overrides all the visceral reflexes. And the example I gave you previously was blood pressure. Maybe in the moment, blood pressure is a little high. A visceral reflex called the baroreceptor reflex is acting to bring it down by increasing parasympathetic output to the heart and turning down the sympathetic dial to the heart. But as that's happening, let's say there's a loud explosion. Someone's yelling, evacuate. You got to jam out of the room. You're running for your life. Now you're in fight or flight. The hypothalamus overrides that reduction in blood pressure that the visceral reflexes were carrying out and actually increases heart rate and increases blood pressure, even though it's already high. Right? We're going to override the reflex, ignore the set point, and get that blood pressure nice and high because that's the driving force for blood flow. And we have to make sure during fight or flight that skeletal muscles and heart muscle get extra blood flow. If you're not dealing with a stress, if you're in resting mode, visceral reflexes are taking care of all your autonomic output. Hypothalamus doesn't really need to do anything. The end.